Hi, Dr. Brian Kaufman, a retired family doctor and a CLL patient myself for 17 years, and the co-founder, executive vice president, chief medical officer of the CLL Society here at ASH 2022.
Hi, I'm Dr. Christine Ryan from Dana-Farber Cancer Institute in Boston. I'm a third-year fellow in the Hematology Oncology program, and thank you for having me.
Dr. Ryan, we've heard a lot about combination therapies in CLL, and we've also heard a lot about one of the greatest unmet needs in CLL, which is Richter's transformation when CLL goes bad. Unfortunately, it doesn't happen to too many patients, but you did some research and published an update from a phase 1/2, so a fairly early study of Duvelisib, which is a PI3 kinase inhibitor, and Venetoclax, which is a BCL2 inhibitor, both very strong medications in CLL, in patients with relapsed or refractory chronic lymphocytic leukemia, so these patients have failed other therapies, or Richter's transformation. So you, again, worked with Dr. Davids and the rest of your team on that. Can you tell us a little about why you did this study, what you were looking at, and explain it to us?
Yeah, absolutely. So, I think as you're mentioning, a lot of our treatment in CLL right now is employing different drugs and trying to put them together in effective combinations. And so, Dr. Davids had actually done some preclinical work looking at Duvelisib in combination with Venetoclax and found that when we treat cells with the Duvelisib, it actually increases their dependence on the very thing that the Venetoclax targets. And so in a way, sensitizes them to the Venetoclax. And so that really empowered us to think that by combining these two drugs and giving them to patients that we could more effectively treat their CLL.
So you had the rationale, what we call the preclinical data.
Yeah.
So you put this study together. So tell us a little bit about the study design and give us a little bit of a sense of how it's gone. And I'm interested both in the good and the bad. What were the adverse events? Duvelisib is a PI3 kinase that can be relatively toxic. Venetoclax is quite immunosuppressive, can have issues. So I want to hear about the safety, and then we can talk about the good stuff, what the results were.
Okay.
Yeah.
So just a little bit about the study design. As you had mentioned, this was a phase 1/2 study. So actually the first part of the study was investigating the safest doses to be used of these two drugs in combination, because this was the first time these two drugs were being used together. Those results were actually reported at a previous ASH by Dr. Jennifer Crombie, who is the lead investigator of the study as well. And so, in short, what we found that basically the standard doses of these drugs when they're given individually were the safest doses to be used when they were given together. So with that, we were able to then continue on with the enrollment of patients as part of the phase 2 portion of the study. And so in total—
Which is more looking at efficacy.
Exactly.
The first part is safety.
Right.
And dosing, safety, and then the second part is safety and efficacy. You really don't look at efficacy in phase 1. But
exactly.
Wink, wink, we really do look at efficacy, but that's not how we design the trials.
Right. That's not necessarily the purpose of it, but we definitely do get an early look at that. So in this ASH, what we're reporting as these updated results, we include 35 patients with CLL as well as 8 patients with Richter syndrome. And I will say, importantly, the patients with CLL who were included, a good number of them had actually been treated with a prior BTK inhibitor. So in particular for these patients, it was ibrutinib. And so this study was being opened at a time where we were seeing patients who had progressed or had their disease come back while on ibrutinib, and wanting to then treat with potentially an effective combination in that setting.
All right, so tell us a little bit about what kind of adverse events you saw, because Duvelisib is a controversial drug, and it's had significant adverse events, as the whole PI3 kinase family has.
Yeah.
And Venetoclax, like we say, is immunosuppressive of other issues. So what happened when you put the two together?
Yeah, that's a great question. So, we did see some of the kind of more characteristic toxicities of the PI3 kinase inhibitors, things like particularly with regard to GI issues, diarrhea, colitis, and some infections, but they were overall manageable. And the other component of toxicities that we always think about is the hematologic side, so things like, are the blood counts getting lowered?
Right.
And we did see a fair number of patients in the study who, with the combination of these drugs, did have that, we call that cytopenias.
Which is low blood counts.
Yes, yes. But we were able to use growth factor support to manage that. And so, while there were these toxicities observed, they were overall quite manageable.
And you mentioned infections. Was that significant? And were there, any higher, more severe infections?
There were a few what we call kind of higher grade or more severe infections. There were cases of COVID, and these were patients that kind of, the COVID wave came and took us all by surprise. So these were patients that, really had very little protection to COVID at all. And so we did see some less favorable outcomes with their infections, but we're able to get them through.
And did you lose any patients in the trial?
So we did, and in some patients due to disease progression, that was particularly in our patients with Richter syndrome, as we have discussed. Richter syndrome is very challenging to treat and very much an area of unmet need. And so we did have one patient who had passed away with Richter syndrome.
Well, let's talk about the results, and I don't know if you want to divide it up in terms of the CLL patients or the Richters, but was it an effective combination? Did it add oomph to because both of those alone have some activity in Richters and have significant activity in CLL, but not really great in Richter, so I'm really interested in hearing what the results were.
Yeah, so with the patients, the CLL cohort, we did see high rates of clinical response, very high rates of actually overall response, but complete responses we saw high rates of. We also saw high rates of undetectable MRD in the bone marrow, and so that is basically looking for the CLL at a very low level, what we call a molecular level, and we're looking for this MRD or measurable residual disease. And so when we say undetectable, that means that we basically can't find evidence
less than 1 in 10,000 cells, I imagine.
Exactly, yep. So we couldn't find the CLL in a good number of the patients. It was actually around 40% of the patients who had that undetectable MRD in the bone marrow.
So very good responses in CLL. What about the Richters?
So, as we've talked about, Richter syndrome is a very hard to treat patient population. We had 2 patients, so there were only 8 patients on the study who had Richter syndrome, and so, a very small sample size. There were 2 patients who achieved a complete response, and one of those patients actually was able to go on to receive an allogeneic stem cell transplant.
Which is generally the standard of care, right?
It really is. So a lot of the times our goal with Richter's syndrome patients, the goal is to be able to treat that Richter's transformation so that it is under enough control that the patient can go on to an allogeneic transplant if they are eligible to receive a transplant. So we were encouraged by that, even though, of course, it was small numbers.
Well, anything that we can do for Richters, because it's such a screaming unmet need. Do we have any durability data yet, or in terms of the CLL and the Richters?
Yep, so for the CLL patients, we do have a sort of more extended follow-up, and we're seeing high rates of what we call progression-free survival, so duration of time without having the CLL come back and patients remaining alive. It was above 70% at about 3 years of follow-up, 2 years of follow-up. The Richter syndrome, again, it's a very small sample size, so it's a little bit harder to kind of give percentages with that.
Any final thoughts or conclusions from the study that you'd want to share with patients?
I think that we're very excited about this combination, as we are with just combinations of novel agents in general in CLL and Richter's. I think I'm definitely encouraged by the responses that we saw in Richter's transformation patients, but also definitely speaks to the need for continued research in those patients in particular.
And I would say this, and I'd love to put you on the spot here, Dr. Davids and the CLL Society, myself, have been strong advocates to keep the PI3 kinase inhibitors as part of the armamentarium, and this is another reason to do that. I mean, we're not sure that we're going to have Duvelisib as an option for patients in 2023.
Yeah, I think that those of us in this field who have had patients that we've treated with it, who we've seen these responses, especially patients who otherwise have very limited treatment options, we are very, very much wanting to be able to still offer this as a treatment option for our patients, and think that it can do a lot of good in terms of helping patients with CLL.
Dr. Ryan, we're so happy to have you on our side as a patient and doing this research. We're so excited. Thank you so much for what you're doing for CLL patients.
Well, thank you, and thank you very much for having me.
Thanks.